Hello, I'm Ellen Bubrick, and today we're going to be talking about non-pharmacologic treatments for epilepsy. We'll start by defining drug-resistant epilepsy and identify those who have it, recognize the importance of identifying patients earlier in the course of the disorder and the risks of ongoing seizures, and we'll become familiar with the non-pharmacologic treatments such as surgery and other treatments and their potential benefits. We'll look at this from a few different angles. The first, and probably the most important still, is surgical options. We'll talk about resective surgery, laser ablation, and a few palliative options. Then we'll move into neurostimulation and neuromodulation, including vagal nerve stimulation, responsive neurostimulation, deep brain stimulation, and transcranial magnetic stimulation. And then we'll end with a few words on dietary therapies. So when would we not use medications? The most common is when the medications don't work. These are difficult seizure disorders to control, and sometimes medications are not sufficient, and we need to think about other options. The medications themselves may be intolerable. They're very, very difficult for some patients to maintain their normal functioning on these medications, and sometimes it's associated with a lower quality of life. So if we can give them another option so they don't have to have as much medication or as many medications or as high of a dose, we want to give other options. We also have to look at other things that could be exacerbating the illness. If they have, for example, uncontrolled sleep apnea, sometimes no matter how much medication you give them for the seizures, without treating the sleep apnea, they could have worse seizures. So we always want to think about if there's other illnesses that could be exacerbating the disorder. Sometimes it's just patient preference, and they'll say, is there anything else you can do for me besides medications? And of course, we don't use medications if it's not epilepsy. A little bit about the demographics of this disease. Epilepsy is a very common neurologic disorder. 3.5 million people in the US, 65 million worldwide. That 3.5 million in the US is 3 times that of Parkinson's and multiple sclerosis combined. So we're talking about a very, very common disorder. 2/3 of patients with epilepsy are well controlled on anti-epileptic drugs. Now we say anti-seizure medications. So going forward after this slide, I'll use ASM instead of AEDs. 2/3 do well on medications, and that's terrific when that happens and we can get them feeling good. But about a third have persistent seizures despite their medication. So it's a third of a huge number of patients. So it's a very large population we're talking about. We used to use terms like refractory, intractable, pharmacoresistant until 2010. The International League Against Epilepsy came up with a consensus paper using the term drug-resistant epilepsy. And they really defined drug-resistant epilepsy, which has been the standard definition used since, as failure of 2 tolerated and appropriately chosen and used AEDs, whether it's monotherapy or in combination, to achieve sustained seizure freedom. So if we look at those key words, tolerated, appropriate, and used, we look a little bit at making sure we're talking about true drug resistance and not what we call pseudo-resistance. So first, we want to make sure that the diagnosis is correct. If somebody has failed 2 or more medications, we bring them in for long-term video EEG monitoring to try to capture their spells and try to understand why they're not responding. We evaluate if the medication, the anti-seizure medication, is appropriate for that seizure type. Maybe somebody came in on a drug we use for partial epilepsies like carbamazepine when really it's a generalized epilepsy, and so that could be why they're worse. We always want to make sure it's the right medication for the right epilepsy syndrome or epilepsy type. We want to make sure the dose has been optimized. Sometimes people come in with a lamotrigine level that's 2.9 or 3.3, and they're still having seizures, where some patients need to get up to a level closer to 10 to achieve seizure control. We want to confirm good medication adherence, remove aggravating medications, and we always want to optimize treatment of other comorbidities. We talked about sleep apnea. We always want to make sure we've talked to our patients about substance use, untreated psychiatric illness, and so on. So the Kwan and Brody article was the first study that really put demographics of drug-resistant epilepsy on the map. This was a New England Journal article where they showed that we can get about 47%, almost half of patients seizure-free with the first drug trial. If they fail the first drug trial, we can squeeze out another 13% to get seizure-free with a second drug. But beyond that, you really only have a 1 to 4 chance of becoming seizure-free once you've failed 2 drugs. There's always this approximately third that remain